All right, thanks and welcome back, and thanks for coming back. And welcome to anyone new who's popped into the room. We're just going to get started with our short snapshots. So we'll be having 3 speakers from around the region. And in the next 90 minutes, we'll hear presentations from 3 psychologists. They will be presenting as a panel, and we'll take your questions at the end of the presentations. So first up will be Dr. Heather Fulton, and then when she's finished, she'll just take a seat here, and then you'll have an opportunity to ask questions to all 3 of the panel members at the end of the talk. And then we'll break for lunch from that perspective. I'm very pleased to welcome our first presenter of the snapshots from around the region, who is Dr. Heather Fulton. And Heather is a psychologist in Burnaby Center for Mental Health and Addictions. She has been studying concurrent disorders for the past 9 years and using both animal and human models. Her dissertation investigated initiation and escalation of prescription opioid use by clients in a harm reduction methadone maintenance program. She also examined how ongoing mental health symptoms were related to ongoing substance use by clients in that program. She has been involved in and published other studies examining such topics as tobacco use, adolescent substance use initiation, and the relationship between cannabis use and psychosis. If you could all please help and welcome Dr. Heather Fulton. Thank you.
Oh, is this, hold on, which one's the slide? That one?
Yeah.
Okay, thank you. Okay, so, sorry, there's so many places to look. I'm getting disoriented here. Okay, so what I'm going to talk about today, I only have half an hour with a very packed agenda. So first I was thinking I'd talk about, well, what are concurrent disorders and why do we need concurrent disorder approaches, treatment approaches? Because sometimes there can be some definition issues. I want to make sure we're all on the same page first. Then I wanted to present sort of a couple of evidence-based psychosocial treatments for concurrent disorders. And then I also know, at least whenever I've been in a conference like this, where it's, oh, that's very nice, that's what the literature says, but how do we actually do that? So I thought I'd give you guys some suggestions for implementation and how we've implemented these different treatment approaches at Burnaby Center. Then at the end, I have it packed full of practical, useful, and most importantly, free resources if you'd like some more information. Okay, so one thing that I think is really important to do is if you ever have worked in the addiction field, you know that there's some very strong personalities. There's lots of experts saying, oh, you know, you must treat addiction this way, you must do this, never do that, this is how reality actually is. But you know what, in reality, it's a developing field. We're really working on research, more data, more sharing of the resources we have, especially with concurrent disorders. Addiction is not very well understood, but concurrent disorders in particular, because it's so complicated. So one caveat I will say is, you know what? In 5 years, I might have a very different lecture, but I'm going to tell you this is where the evidence is right now. Because ultimately, I really do believe that the best decisions for treatment are really based on data, evidence-informed theory, rather than personal experiences of, oh, my recovery story's like this, or I had a client. You know, those are useful, but really we want to go to the data, the evidence-supported information. Okay, so concurrent disorders. Sometimes you'll see in the literature that they're called dual diagnosis or dual disorders. So concurrent disorders is much more frequently used in Canada, and what we mean here is it's a substance use disorder plus another mental illness. Dual diagnosis, particularly in the US, can also refer to, say, concurrent disorders, as in a substance use disorder plus another mental illness. But sometimes you can see just it's a medical illness plus any mental illness. That might be addiction, it might be depression. So if you had a client with depression plus, say, diabetes, someone could say that that's dual disorders. In Canada, when we say dual diagnosis or dual disorders, it's much more common that people are actually referring to developmental disabilities plus any mental illness. That can include an addiction, but not necessarily. So I want to be really clear here where I'm going to be talking about substance use disorders or addictions plus another mental illness. Okay, so first of all, why do any of us care about this? Why, I work in general mental health. I don't see addiction clients. Well, first of all, even if you're in the addiction field, why do I care about mental illness? I refer out to that. I think it's really important that some of the most conservative estimates that we have is people who are seeking help for a substance use disorder, and at the time this included substance abuse and substance dependence because they are using DSM-4 criteria. About 50% of them have a concurrent mental illness. So if you're in the addiction field, you can pretty much safely bet that you have concurrent disorder clients. But for those of you who say, oh, well, I'm in general mental health, I don't deal with addictions, well, again, the most conservative estimates are really saying about 15 to 20% of those seeking help for mental illness have concurrent substance use disorder issues. So if you think, I don't see these clients, I would say think again, and have you actually assessed for that? Are you really looking for it? Especially because a lot of the best practice recommendations say, well, if you treat one of these conditions without addressing the other, treatment is likely to be ineffective. Now, that doesn't mean we all have to become Burnaby Center and be integrated concurrent, right? So these are some of the recommendations from the Substance Abuse Mental Health Services Association, Administration, and there's also from CAMH, where, okay, how do we treat folks? Where if you have low severity of mental illness, low severity of substance use issues, probably primary care is sufficient. The high severity folks for mental illness, which is what many people probably in this audience are used to, okay, probably specialized mental health service, which is some consultation to addiction services, some collaborative care is probably best and sufficient. Same way if you have someone who's sort of more predominantly addiction, just some collaboration, consultation with those mental health services might be sufficient. But if you have someone who has high severity in mental illness, high severity in substance use issues, you're really going to want to have that integrated care throughout. Now, I could talk for forever about why psychologists should really treat drug and alcohol problem, why all mental health care professionals need to know, but I also know I only got half an hour, so I wasn't allowed to go into this too much. But I want to give you some references of, if you're not totally sold on why I should develop some expertise in this area, I'd strongly suggest checking out these articles. I also think, especially as psychologists, we have some unique skill sets that make us really well prepared to add to drug and alcohol treatment, and often we're missing there. And you're in your training, you have so much, so you're so close to being able to treat this. Of course, practice within your area of competency, but you already have some of those foundational skills. So just need a little bit of extra if you really want to treat this. All right, so now what are some evidence-based treatment approaches? There's a number out there, but I thought I'd focus on sort of 4 big ones that I thought were more easy to incorporate into treatment, but also were more well-known as well. And then, of course, I said I'd be giving you ideas for how to actually implement these in a realistic treatment setting. All right, so first of all is motivational interviewing. So I think probably most of you are familiar with this one. Sometimes it's called motivational enhancement. If you talk to someone who's sort of a hardcore motivational interviewing person, they'll say, oh, they're very different approaches. They're kind of similar, in my opinion. Motivational enhancement was more developed for a randomized control trial, so they are a little bit different, but they're very similar as well. Essentially, what both of these are really emphasizing is examining, resolving ambivalence about changing behavior. One thing that's really important to remember is the spirit of motivational interviewing is the most important. So if you look at RCTs of motivational interviewing, those people who stuck most closely to the manual, their clients did worse. Anyone want to guess why that is? Got no guesses. Colleen. Yeah, you're kind of going with the RCT treatment manual. It's session 3. Okay, we're supposed to be in the action phase, and you're going with the action phase. Meanwhile, the client, okay, they're not totally ready yet. They're still in the ambivalence. Maybe some more work needs to be done on that decisional balance piece, and actually resolving the ambivalence. But if you're stuck on, oh no, it's session 3, I'm supposed to be doing this, 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 you're not really going with the client. So if you're ever wondering and sort of sometimes doubting your skills of what am I supposed to be doing, again, really it's that emphasis on the spirit, the collaboration, evoking from the client, emphasizing their autonomy. One thing I really like about motivational interviewing is even 2 sessions can have sustained effects over treatment. It can be used with a lot of different approaches. So there's a lot of evidence out there of using motivational interviewing with diabetes, with depression, with eating disorders. So it's really nice that it can incorporate into all sorts of different mental illnesses as well as addictions. So how do we do it at Burnaby Center? Well, first of all, there was a commitment by our management for staff training. So all full-time staff attend 2-day training, which is really important at a systems level. But anyone who's ever gone to a workshop, you know, okay, workshop's all well and good, then you get back to work, you try it out maybe, and oh, this wasn't like the role play, and you know, it's maybe a bit harder, and then usually you don't use it anymore. So you have to have that sustained support if this is actually going to get used. So one thing we've been experimenting with, and we've done this a couple different ways, but right now we have unit case rounds on our acute unit where we can problem solve about lots of different case issues, but one option is problem solving around motivational interviewing issues. So we have someone who really wants to leave treatment, they're certified, you know, is there anything we can do? What would be some motivational approaches and sort of problem solving around that? One thing we just started about last week is, and I know you can't see those, it's really tiny, is we have these new motivational interviewing posters where it's sort of what to say, when to say it, based on the stage of change that a person is at. So if we have someone who's really ambivalent, okay, try focusing and doing prompting questions like this. If it's someone who's really devoted, yes, I want to go and do treatment, I'm totally committed, okay, try these kinds of questions when you're talking to a client. And nurses and healthcare workers have reported that they really like these posters and that's really, really helpful. Another thing that I do actually with Daniela, a social worker here, is we have a Talking About Change motivational interviewing group. So we do some of the basic motivational interviewing techniques, but we do it as a group to start getting them to think about maybe why might I use substances, what are some good and bad things. We also have an art of change group. So our art therapist, she goes through some very similar motivational interviewing approaches, but people instead are drawing themselves. So where I'm at and drawing a picture versus where I'd like to be. How do I get from where I'm at to where I'm like to be? And so that's really neat for a sort of a nonverbal approach. And then also we use motivational interviewing principles throughout our smoke-free initiatives as well as in anger management. So we had so much dropout in this group. So now our first session, all it is really motivational interviewing for these people who've been referred to our anger management group. All right, so the next one I'm going to go through is contingency management. So some people may or may not be familiar with this. This essentially is based on operant conditioning, so rewarding people for engaging in healthy behavior. Some people, when you tell them about this, they say, oh, well, this seems kind of harsh, this seems really punishing. Well, and I would really argue, well, our clients are in our treatment centers are very familiar with pain and punishment, right? We want to be able to give them positive reinforcements for small steps on that recovery journey. Recovery is really hard work, so anything we can do to help encourage that process along is really important. Especially with addictions, you're not having sort of that alternative types of reinforcement for those behaviors. It's really all been reinforcement through substance use. So anything that we can do that enhances that reward, and especially if it's incongruent with substance use, can be really helpful. Again, some people are like, oh, I don't know, it seems kind of demeaning to clients. Well, actually, here's a really great quote from Kellogg, and was cited again in a number of other documents, is, while aversive and punitive methods have been used to reach goals, say if you think about, say, old style like confrontation of clients, doing interventions, if you don't do this, we will do this, the systematic use of positive reinforcements or pleasurable consequences has been associated with humanistic efforts to improve problematic individual or social conditions. And this is throughout, actually, history. If you look at sort of positive reinforcement support for change, That's when you actually get behavior change, not threats, not punishment. True behavior change usually comes from support, not punishment. Now, there's probably some of you out there who say, well, okay, I kind of get this, but that kind of thing would never work on me. And I would say, are you sure none of you have any of these cards in your wallet? Because this is contingency management in action. So how do we do it at Burnaby Center? So we have some, they're not really mandatory groups, but there's 3 daily groups that we say are really important for clients to go to. If they go to them, they get extended passes, so they go out for longer on the weekends. They also get draws from a fishbowl for various prizes. So it can be things that usually are desirable and enrich healthy behaviors, like having an alarm clock, stress balls. Then we also have other therapeutic groups where we really want people to go to, but if you get a pass, that's something else. We just really want to reinforce this behavior. So it might be going to acupuncture, your CBT group. So they get a voucher if they attend these. Then, once they have vouchers, they can cash in those vouchers for other items. So they can get pop, they can get batteries, there's even MP3 players or bus tickets, and they all vary on their cost amount. One thing, people often won't do contingency management because they say, well, how are we going to track this? It seems really burdensome. Well, actually on Paris, there is a way to track that. So everything is done via the computer, so it actually is a simple way to track group attendance and then use it for your contingency management program. One thing I will say is other addiction centers, often you'll hear about contingency management for drug-free urine screens. And so yes, I agree, being sober is important and you want to reward that, but there's a whole lot of other healthy behaviors, especially you can think of things related to mental illness like behavioral activation, those kinds of things that you really want to reward as well, not just a drug-free urine screen. All right, next evidence-based treatment I really want to talk about is seeking safety. I know in Vancouver there's a lot more of seeking safety programs and training in this than there is sort of more on the East Coast. So most of you are probably familiar with this. It's developed by Lisa Najovitz. It's to treat PTSD and substance use, but it can be used just for PTSD or just for substance use, or it can be used for both disorders. I really like this therapy because it's very present-focused, it's very coping skills-based. You can do it in a group or individual therapy. It also has flexible format, so you can switch around the order of the sessions and it still works. It's still evidence-based. You can maybe, hey, we need more work on boundaries. Okay, we can extend that for, say, 2 or 3 sessions. That's okay. It's still evidence-based. Lisa Najovitz says that's totally all right. And it's been shown to be effective in a wide variety of populations. So men, women, veterans, homeless individuals, there's some really good research showing it's effective in all of them. How do we do it at Burnaby Center? So one thing is we're continuing to develop and evaluate this. And so we do this through questionnaires, we do client feedback as well, and then also client attendance. Are they actually coming to this group? Because if they're not coming, maybe they're not finding it helpful. So we are always constantly evaluating this. We also keep our groups gender specific. So we have a women's group run by 2 female therapists, a social worker and an art therapist. It's twice per week, 1.5 hours per session, and it's a closed group. And it has an art component, so they'll draw and do some art therapy activities to kind of really cement the things that they learned in the more typical seeking safety session. And they're working actually and been consulting with Lisa Najovitz about how to really evaluate this and hopefully publish it in the future. Here's our men's group. So you don't hear about these ones as often. It's run by an OT and myself. I'm obviously the only woman that's in that group. We run it once per week, and it's 1 hour, and it's open. So it's a rolling attendance, but we always do a pre-screen so people know the group rules, that it's really present-focused, that sort of thing. We don't have an art component, and often, because we only have 1 hour a week, we can't get through all that content. Especially at Burnaby Center, where we have some more cognitive impairment, we need to make things more concrete and have some more repetition. We often will extend those sessions over weeks. So the boundary sessions, I think we had three sessions on that, so 3 hours, which is quite different from just one session. We also use the suggestions from Lisa Najovitz on how to modify this content for men. And that's the link to that article there. Of course, you can find it on our Seeking Safety website as well. All right, CBT for addictions. So this one I'm really passionate about because I find most people do not know about CBT for addictions or don't use it, and it's so fantastic because it so nicely rolls into treatment for other disorders as well. One thing, if you start Googling CBT for addictions, it gets very confusing. Where it's like, is this relapse prevention? Is it coping skills training? I'm so confused. Like, there's this Beck book. I don't know. What am I supposed to be doing? The more research I do into it, and the more I actually use it myself, they're really kind of similar. They would probably disagree with me, but they're very similar, and you're always using very similar approaches in both of them. I think both of them share very similar elements, but both between separately in RCTs are evidence-based treatments. One thing you'll notice is I say MARLAT's relapse prevention. There are other types of relapse prevention programs out there that are not MARLAT's relapse prevention. So one really prominent one is by Gorski, and there's lots of books out there, and I'm not saying Gorski's relapse prevention isn't good, but Gorski, he was a drug counselor, and after sort of 40 years, put a book together and said, this is relapse prevention. And might have very helpful and very good things in it, but it hasn't actually been evaluated yet. So we don't know if that's evidence-based or not. It might have very good things in it, but we don't know. It's not an evidence-based treatment just yet because no one's evaluated it. So that's why I'm really emphasizing MARLAT's relapse prevention. You can see there all CBT therapists are probably familiar with that thoughts-emotion triangle. All right, so I'm going to quickly take you through this model. This is why does someone continue to drink or continue to use substances despite wanting to stop? So it's not why is someone starting to use, why did they develop problems? This is why are they still using? And that's an important thing to remember. So first of all, we have a high-risk situation. So this could be walking past a pub, it could be walking on the downtown east side, could be someone offers you drugs. You really want to identify the antecedents and determinants. Next, you want to know what needs are being met by substance use. So we know someone who continues to use despite not wanting to, they go to that high-risk situation, say someone offers them drugs, but there's a no coping response or an unhelpful coping response, as in they just say, no, I'm okay. That's not a firm no. It kind of is sort of like, come on, convince me. So that might not be a very effective coping response. Or perhaps they have anxiety, and they say, oh, well, I'll just white-knuckle it through. I'll be okay. But then they find out, well, that's not working so well. I'm still really anxious. So they have decreased self-efficacy, as in, I can't actually just handle my anxiety. And then they start having positive outcome expectancies, like, and that's really being emphasized and activated, like, what would really help my anxiety is alcohol. Alcohol or drugs, they always do the trick. And so that usually leads to initial use of a substance, and then there's the abstinence violation effect, or how I always describe it to clients is calling it the fuck it factor. As in, I drank, fuck it, I'm back at square one, screw it, and then they start drinking again. If you explain it as the fuck it factor, people remember. Abstinence violation effect, their eyes glaze over. So what we want to do so we've described the model. What we want to do is we want to really talk to them and say relapse is expected and an opportunity to learn. Identifying what are the immediate antecedents or determinants. So sometimes clients call them triggers. So what are those high-risk situations, both emotional, so internal, as well as environmental? Really increase those coping skills. Really kind of question sometimes their outcome expectancies. Like, okay, maybe alcohol does, decrease anxiety. But what happens next? And what happens after that? And, maybe with withdrawal symptoms, you actually have increased anxiety, and you have the guilt, and you have depression, and. So really challenging some of those outcome expectancies, and then telling them about the abstinence violation effect, where, you took that first drink, that's a big deal. But you know what? You're not back at square one yet. If you have been drinking since you were 13, you've never had 30 days sober, now you've had 30 days sober and you took a first sip, it's not that it's no big deal, but you're certainly not back at square one. So really emphasizing that to them, increasing the skills, really that practice is so important for them, increasing their self-efficacy and knowing, okay, I can actually do that, eliminating myths, managing lapses. And one thing you'll notice going through these manuals is the techniques are very similar to those used in treatment for other mental illnesses. So thought records, behavioral experiments, try it out, let me know how it went, doing some behavior activation. So how do we do this at Burnaby Center? Well, we do have a variety of CBT groups, but a lot of them have been modified to actually incorporate sometimes substance use. Like, so you feel really depressed, what kind of thoughts do you have? Sometimes those thoughts are going to be using thoughts. So then, of course, we want to start tackling those and doing some Socratic questioning for those kinds of things. We also have coping skills practice, matrix, a CBT intervention. 5 minutes, got it. We also have mindfulness-based relapse prevention. So Marlette, towards the end of his career, really was emphasizing relapse prevention with a mindfulness component, so incorporating urge surfing, that sort of thing, which has been used in prisons and lots of other really neat populations, which suggests that'd be very applicable if you are working with people with severe addictions and mental illness. We also are getting all staff trained on functional analysis, which is kind of a key relapse prevention technique. So really, what are the triggers? What were your thoughts, feelings, behaviors? How did you cope? What happened next? All right, so don't worry, I'm pretty much done. So here's the free resource part. So relapse prevention. All right, here's some really nice write-ups on the Knowledge Exchange at CAMH. And the Seen the Snap thing is the Canadian Network of Substance Abuse and Addiction Professionals. They have a whole bunch of really nice resources on that website, so I'd strongly suggest checking it out. Coping skills training. There's Project Match treatment manual. So that was an RCT they did. It's really specific on alcohol use. So our program, at least the Burnaby Center, is much more based on this NIDA RCT manual, which was looking at cocaine addiction. And that's because we have people with diverse substance use. Then other further resources, SAMHSA has some treatment improvement protocols. So they review literature, they have all nice suggestions. There's ones on, treating women with addiction, treating chronic pain and addiction, has so many really good resources. So I'd strongly suggest that. There's the Health Canada best practices. It's getting kind of old, but, it's worth checking out. Then I mentioned, the Canadian Network of Substance Abuse and, allied professionals. Then further resources, there's the Motivational Interviewing website. There's a good contingency management website if you want to learn about sort of a toolkit and materials to do it there at your program. There's a Seeking Safety website. BC Here to Help has some really neat self-help resources on sort of reducing substance use. One thing, I really want to emphasize that Evaluate Your Drinking website. It's really cool, so I really suggest you check it out. You can go and sign in as a treatment professional, and it's alcohol-specific only, but you can type in, and I've done it with a number of clients as sort of a motivational intervention where they say, I don't have a drinking problem, I drink just as much as my friends. And that may be true, but, let's look at your alcohol use if there's any problems. So if you type in how much you drink per week, the price of each drink, it'll go and tally it up and say, how do you compare to other people your age and gender? What is the cost per year of drinking? How long does it take for all that alcohol to get metabolized through your body? What are all the different risks associated with that? And it's a really cool intervention to really kind of test out some of those predictions of, I can handle it, I'm totally fine, and yeah, my doctor said I shouldn't have any more because of my liver, but I'm okay. You can be like, well, let's look it up. And because it's Canadian stats, it's really cool. There's an American one, but I like the Canadian one, of course. And you can always talk to me, and if I can't answer it, I can refer you to other folks at the Burnaby Center. And that's it. Okay.
Thanks. I'm just going to do a switcheroo with the technology, and I'll ask Mahesh to come down if we need to. Trina, yeah. I'll ask the presenters, and if they say yes, then I'll put them up. Today is also being videotaped, so the entire conference day will be up on our website. Hey. It's my attachment stuff. Thank you. Okay. Good. Okay. So our next presenter is Dr. Melody Priest, who is a psychologist at the Solid Organ Transplant Service at Vancouver General Hospital. Melody has a special interest in psychiatric comorbidities and transgender people. She also is a clinical assistant professor in the Department of Family Practice, Faculty of Medicine at UBC. She also maintains a small private practice, conducting assessments and working with transgender individuals. Melody, if you'd like to join us. Thank you.
Yeah. Oh, you can. Oh, love it. God, I love technology. Isn't it great? Hi. So, I'm actually the data-heavy talk today. I apologize for that. I've had a lot of training in working with transgender people, and it's always been very focused on sort of trying to understand them, and I always wanted some data, and it was hard to come by. So in this talk, I hope to persuade you of a few things. One is that gender variance is a lot more prevalent than we used to think. Another is that severe mental illness is no more prevalent in the transgender population than in the general population, and that the increase that we see in mood and anxiety and substance use disorders in transgender people can be understood as a normal reaction to the challenges they have with regard to gender dysphoria and the extraordinary challenges they have with regard to familial and societal rejection and discrimination. I'll also touch a bit on the high rates of suicidality that we see in transgender people and propose that is not a symptom of mental illness, but rather a reaction to their situation in terms of their societal role. I hate this part of all talks about transgender people, is where we go through the, what we call and what this means. I say transgender because it's kind of an all-encompassing term. I just want you to know that most of the research is done on transsexuals. A transsexual is somebody who identifies clearly in the opposite gender and wants to live as the opposite gender and has to access medical treatment in order to do so. There are many, many varieties of gender variants that are not well studied. So, although I may say transgender, the research I'm quoting is mostly based on research on people who have actually accessed medical treatment of some sort. And I might say cisgender at times. Cisgender is just a simple way of saying those of us who are not transgender. It's not a slur or anything. I just try to avoid saying the normal population because I don't like that. So cisgender is just kind of the other folks. Okay? And that's all my definitions. If you read some of the early research on transsexualism, it's extraordinarily pathologizing. Some of that research has been done by psychologists, Canadian ones even. However, these are the kind of things that have been said about transsexuals in the past, that they're all borderline psychotics, that it's a variant of a personality disorder, and that many people, in the 60s and 70s and 80s felt that for us to listen to what transgender people tell us about their experience and what their needs are is extraordinarily foolish. And that just because they tell us psychotherapy isn't effective for them, we should not listen to that. Things have changed. We've got a paradigm shift in terms of how we treat transgender people. And certainly there are more and more researchers who are demonstrating that we can't assume that all people who have gender variance or who are transsexual are necessarily psychiatrically ill or mentally ill, but that perhaps just their experience in our culture has caused them to have these increased symptoms. I love the prevalence research. When I started working with transgender people 9 years ago, They told me, said in the DSM too, it's about 1 in 12,000 males and 1 in 30,000 females. So it's like so rare that nobody will hardly ever run into any, right? But people have challenged those prevalence numbers. Lynn Conway, who is somebody who transitioned herself and was a professor in Michigan, I think, she worked with an epidemiologist and did some interesting prevalence research. And she went the opposite way. She went to plastic surgeons in the United States who provide sex reassignment surgery, now more politically correctly called gender affirming surgery, but that's what I mean. And she went backwards, like how many surgeries have been done in the United States on people who wish to change their gender, and she found about 1 in 2,500 United States citizens has had a complete transition, including surgery. That's a lot more, isn't it? And then they had various ways of extrapolating this that I can't explain, but it's all detailed in her papers. About 1 in 1,000 has transitioned except for surgery. Certainly until recently, accessing any kind of expensive surgery like that for a transgender person in the United States was virtually impossible unless you had a lot of money. So that's probably a closer prevalence. And then she suggested that maybe 1 in 500 actually have these strong transgender feelings. A nice study in the UK that was actually funded by I think they call it the Home Office or something. Sounds like James Bond. They did a study in the UK because they can look through their national service how many people have requested help. And they came up with about 1 in 500 wanting. What they did is they wanted to predict future, because what we've seen is an increase in people presenting for help. And they predicted that 1 in 500 will probably undergo a full transition in the next 10 years, and that about 1 in 100 might experience some degree of gender variance. In Massachusetts, they did a population survey of their state, and they came up with 1 in 200 people who reported on that survey that they have cross-gender identification, which is a lot. And another study at UCLA, found they extrapolated from a couple of different population surveys of several states who had actually asked that question, and they thought about 1 in 333, 3 in 1,000, report this cross-gender identification, or some degree of it. We have to remember that there's degrees of severity of gender dysphoria. Most of the people who do engage in a complete medical transition are ones who have extremely severe gender dysphoria. Not everyone experiences it to that level. So now we're counting them, and there's lots of them. Way more people than we realized have this experience. And other things have also shifted in response to our understanding. One is the Standards of Care, which is an international document that provides guidelines, clinical guidelines about care for transgender people. And this most recent version, in version 7, has really changed tremendously. First of all, it's the first time that there's references in the back for everything. They've taken a very much evidence-based sort of approach. And no longer is it how do transgender people prove to healthcare professionals that they're transgender, but more how can we provide the care that people need based on their self-report. So it's a kind of a big shift. There used to be this thing where they would say, okay, in order to prove to us that you want to change your gender, you have to do a real life experience. And that means you have to live as the opposite gender for a period of time, which is a very subjective kind of thing because, like, well, what does that look like, you know? Does it mean I need to wear lipstick, earrings, skirts? You know, it's a very kind of subjective thing and sort of a very difficult thing for some people to achieve anyway. So that's gone, thank goodness. People always resented it. They would say, yeah, well, why don't you try a real life experience then? So that is no longer a requirement. And we now acknowledge in the document that people have the right to choose how they wish to express their gender. And it is not for any of us to tell other people how they do that. And we've also, in the new standards of care, reduced this emphasis on a binary model. My greatest fear is that people have accessed medical and surgical treatment because there was only two options available to them: stay the way you are or do the full meal deal, and that is really terrible. And so now it's much more open. If people need hormones to manage their gender dysphoria, but they don't want to transition socially for a variety of reasons, good. That's, you know, people need to do what's the minimum that's required for them to be comfortable. So that is a big change in terms of the standards of care. Also, the DSM-5 has just come out, and there's been some big changes in that too. In the DSM-3, gender identity disorders, it was called, had an exclusionary criteria that it was not due to another mental disorder. So it's kind of like, oh, well, so if you have any mental health condition, and then you can't have gender identity disorder. In the DSM-4, they removed that criteria, so allowing for the possibility of comorbidity, that a person could have gender identity disorder and also have another mental health condition. The DSM-5 has gotten rid of the disorder part. And so now it's called gender dysphoria and really describes the condition that a person is experiencing when they present themselves to us for help. And there's also a caveat for post-transition. So after a person has received treatment, they no longer have the disorder, which was not possible before. Also, they took out all these sexual orientation qualifiers that a lot of people felt were kind of insulting. So it's changed. Things have changed there as well. So I just want to present some research. Most of the good research has been done in the Netherlands. We're kind of behind on that. Just looking at psychiatric comorbidity in children. This study was done in 2007 with 120 children. They used parents' report, and they found that 52% had one or more diagnoses other than gender. So I mean, GID is what they call it in the studies because all of the changes I just told you are very recent. 37% internalizing disorders and 23% externalizing disorders. One of the really awesome things they did in this study was they compared those rates to clinic-referred children with ADHD, and there was no significant difference. So it's more like being a clinic-referred child comes with a lot of comorbidity rather than gender issues themselves are related to this comorbidity. Some of the work by Ken Zucker, his theory was that children develop gender issues because of an underlying anxiety disorder, perhaps separation anxiety. But certainly this research does not support that notion that there's an increase or a difference in children who have gender identity issues. And here's one on adolescents. Looking at adolescents, they found 32.4% had at least one concurrent disorder. What we see is a lot of anxiety symptoms and mood disorder, disruptive disorder. We also see that natal males, that's like people who are born assigned male gender, tend to have more symptomatology. And many of us believe that that is related to a different cultural and societal reaction to little boys who want to wear dresses as opposed to little girls who want to wear pants, right? I made this chart just to point out to you how many people don't have any comorbid psychiatric condition of the number of adolescents who present with gender dysphoria. And in adults, there's a wonderful study I wanted to tell you about. This was done in Europe. I actually presented with the authors of it a couple of years ago. The study's very complicated. It had so many results that everyone's eyes were just like, ah. So I have simplified it tremendously. They had 4 gender clinics in Belgium, the Netherlands, Germany, and Norway, and they did a very good job of diagnosing using the MINI and the SCID-2, using the structured clinical instrument so that they could be consistent. I guess the languages were different, but as consistent as possible across clinics, and they were working together on this, this study. So they looked at both current and lifetime disorders, and they found that certainly transgender people do have higher rates of affective and anxiety disorders than do the, wait, I wrote this down. Yes, than the prevalence for the country. They compared them to population prevalences. They also did an interesting regression analysis to find that there's actually a significant interaction between the country and the gender, showing that male to female transsexuals were significantly more likely to have affective disorders in Germany and Norway than in Belgium and the Netherlands. They didn't want to, say what that might be, but certainly there are cultural differences in how people are, received in different countries, and that seems to, be reflected in the symptoms that people describe. All of these people had less symptomatology currently than they acknowledged having experienced in the past. You'll note that the suicide risk is pretty high also, and I will talk more about what they found in their study was that it did not seem that, let's go, personality disorders. They're at a loss to explain why they didn't find an extreme, a higher number of personality disorders in the people presenting at their clinics, because other studies certainly have done so. There are a number of issues of sampling and convenience. Samples are often used to study transgender people because they're so rare, right? And so this may be more accurate. We don't really know. It is less than previous studies. But they did point out that actually the distribution of personality disorders is in line with epidemiological studies, which does make us think that perhaps it is accurate. So their conclusions are that what they found was that major psychiatric disorders were not found with any greater prevalence than in the general population when they compared to the country's prevalence. They did see that affective and anxiety disorders were more prevalent than in the general population, and they proposed minority stress as an explanation for those higher symptomatology. And as I said about the personality disorders, they also noted that suicidality, suicide risk, was not related or associated with mental health symptoms, as one would expect in the general population, that it seemed to be independent. And they suggested that perhaps gender dysphoria is an independent risk factor for suicidality, not necessarily depression. So another way of helping us understand this increased prevalence is to look at what happens after transition. I'm very excited to have found a review. The transgender research is pretty dismal. Of course, you can't randomize. A lot of studies are done without control groups. So the authors acknowledge in this review that the quality of the studies that they were reviewing was not all that excellent, but it was certainly better than anything we've seen so far. They had 1,833 participants in total. They used an interesting statistic just to show the amount of variability across trials that's not attributable to random error. A statistic I wasn't familiar with, but I like it. So what they found when looking at the studies, they compared the ones that they could, that after transition, there was a significant improvement in gender dysphoria. The treatment works. Gender dysphoria pretty much goes away. 80% of the time. Significant improvement in psychological symptoms, 78% of the time. Significant improvement in quality of life, 80% of the participants, I guess. And a significant improvement in sexual function. Some of the other conclusions, the review's very complex, of course, but they looked at psychological functioning that was measured more carefully with the MMPI and the SCL90. They did find that the psychological functioning was comparable to that of the general population after transition. So this higher incidence that we see when people present seems to go back to the general population norms after treatment. They also looked at some, they also showed that, there are people in the transgender population who have severe psychopathology, just as there are in the general population. And those people, after transition, do retain more psychological symptoms, as one might imagine, and tended to have worse outcomes post-transition. Transition doesn't fix everything. It fixes gender dysphoria, though. They also had some research on hormone use and saw that even hormone treatment showed a decrease in psychopathology and symptomatology after initiation, that it seemed that people continued to improve after they had been on hormones. The longer they had been on them, the less symptoms they seemed to have. And they also showed that suicidality reduced after transition, but it continued to be higher than in the normal population. You're on it? Okay, good. Okay, now I can relax a bit and talk about suicidality. I think the literature on suicidality really has a lot to tell us about ourselves, our culture, how we treat people with gender variance, lots of things. And there's some interesting evidence. So the general population prevalence apparently is 4.6%. This is not just attempts, this is just suicidal ideation and being at risk. We know that the LGB population prevalence is higher, 10 to 20% of people who are LGB report suicidal ideation or attempts. And then in the transgender clinic population, different numbers we find in Europe, 30%. In Japan, a study, 73%, which is kind of interesting because they have that culture, right? 32% reported at least one attempt. In Sweden, there's an interesting study where they did a long-term follow-up of people who had transitioned, who had been in the gender clinics, and they found that there was a higher rate of mortality for transsexuals compared to controls of the same age, birth year, etc. And they compared them to both sexes, both the sex that they were born in and their transition sex, and there was an increased risk of death from suicide or suicide attempts in transgender people post-transition. There's been some pretty good surveys in recent years. In the United States, there was a very big one that had 6,456 survey participants, representatives from every state. It was a nice sample, very representative in terms geographically. And they found 41% of transgender, or in this study they included gender nonconforming people, reported attempting suicide at least once. Huge, right? But it's not just a fluky number, because in Ontario they did a really interesting study, this epidemiologist, using respondent-driven sampling, because it's very hard to know whether you're actually tapping the population. And so she had this method where each person was given like 2 tickets they were allowed to give to 2 people, and this fanned out, because pretty quickly sort of the core group that hang out together were all used up, and people had to start going out and looking for sometimes people who knew only one other transgender person. And so they hopefully, and they weighted the results based on these sort of lone people who were not really associating with a lot of other transgender people. Anyway, she wrote a whole paper about why it's representative. 36% had suicidal ideation in the past year in Ontario, and 10% had attempted. So the numbers are pretty consistent, except for Japan, of course, which is ridiculously high. But there's been some research looking at what the risk factors might be for suicidal issues in trans people. It seems that certainly the same risk factors that are risk factors for anyone are also applicable to trans people: being younger, having depression, having substance use issues, having had trauma like forced sex or rape. But in addition to that, there are all of the other kinds of trauma that transgender people experience related to discrimination, related to victimization based on their status. And many researchers have found that those are also very strong predictors of suicidality. I think it's hard for us to understand, and I know sometimes I'm embarrassed at the things I might have said to people in the past about, oh, most people don't care. It's fine. You're safe. You can walk down the street. This is Vancouver, Now I feel like an idiot, because I've come to understand more about microaggressions and how prevalent they are and how hurtful they can be. It's kind of like an ear flick, One, it's fine, but like all day, it really starts to get to you. And it can be a look of disapproval, a look of annoyance, the pursing of the lips, things that we don't even see. But for a transgender person, there are multiple experiences of that on a daily basis. And one can imagine that that would add up, let alone trying to get ID that actually matches how you're living. That's another whole issue. So the National Transgender Discrimination Survey that was done in the United States, that was the big one with over 6,000 people. They titled it "Injustice at Every Turn." I won't go into all of the results, but it's really quite eye-opening what people have to deal with. And they broke down just their suicidal results. There's all kinds of amazing results in there, but the suicidality results, again, they showed the similar demographic predictors that one sees for suicidality in the general population. And then they had a lovely list of gender-related predictors. So these are the proportion of people reported suicidality who also endorsed these experiences. Everyone knowing that you're transgender. What does that say? I can't see that far. 5? Oh, okay. Being visibly transgender, being rejected by your family, experiencing discrimination, school, work, health care, being harassed, physical, sexual violence, harassed by law enforcement, and physical or sexual violence. This is another study. This is just another result that I think really highlights the impact of rejection on suicidality for transgender people. Just the light bar are people who have families who rejected them when they came out, and the dark bars people who were accepted. And if you look at the suicidality, had attempted suicide, it's I think it says 51% of people whose families rejected them, and although the number is still high, it's much lower for people whose families did not reject them. Again, suggesting that perhaps there's a relationship there. Another study looked at trans people and predicting suicide and showed that perceived support from family was a significant predictor as a protective factor, and emotional stability and child-related concerns, which are very similar protective factors to cis adults. A youth survey also looked at the impact of family support on transgender youth, and you can see that for children who had supportive parents, they had very high life satisfaction, self-esteem, and good mental health, no problems with housing. And for those who had unsupportive parents, they had high rates of depression, high rates of suicide, and of course, high rates of housing problems. So, this is my summary. Am I okay? All right. Oh, I've got a few minutes. So there has been a paradigm shift in the attitude and the understanding of mental health issues in transgender people, and certainly the quality of research has improved. Unfortunately, most of it is in Europe, and some survey studies here. So these common psychiatric concerns that we see in transgender people, symptoms of anxiety, symptoms of depression, they're often subclinical and do improve when they get treatment for their gender concerns. The personality disorders research is not consistent, but most recent studies show similar levels to the general population. And of course, people who have significant mental health concerns prior to treatment are more likely to experience poorer mental health post-treatment. And I think a lot of us, we remember, of course, the people who have the most severe mental health concerns as clinicians, those are the people that we remember. And I think that there's maybe a tendency to start thinking that, well, maybe it's, being transgender and having these severe mental health problems go together. But I've had some clients who had severe mental health problems who did transition in a nail-biting fashion, very, very slowly. And they continue to have mental health problems often, but they always say, the only thing that's going right in my life is my transition. That's great. I still have these other issues, but that is great for me. So I think we have to be a little bit bolder about supporting people and not discounting them just based on their symptomatology. That's all I have to say. Thank you.
Mahesh is going to get his own stuff together. Dr. Mahesh Menon is our next speaker, and Dr. Menon is a clinical neuropsychologist at the BC Psychosis Provincial Program and Inpatient Mood Disorders Program at UBC. I'm going to hand him the microphone, and at UBC Hospital. He completed his PhD at the University of Cambridge, subsequently working in the schizophrenia program at CAMH in Toronto, with his primary clinical responsibilities involved running the psychological assessment service there. I'll just hang up the phone. Can't be that important. Wrong number. Sorry. So Dr. Menon provided neuropsychological assessments to the clients there at CAMH. And in addition, he was involved in providing cognitive behavioral therapy for clients with severe mental illness as part of the CBT service in the schizophrenia program. He has published extensively in the schizophrenia literature with a particular interest in cognitive and neural correlates of delusions and hallucinations. He is currently principal and co-principal investigator on 7 funded research grants. So busy guy, and we're glad to have you here today. Thank you.
Thanks. So the theme for today was the continuity of care. And what I thought I would talk about a little bit was continuity of care at the other end, which is this idea of how do we go from research findings to actual clinical interventions that we've developed. And I was going to use the example of one of the clinical interventions that our group has developed. And a lot of the research, as well as the intervention end of things that I'm going to talk about, are done in close collaboration with 2 of my friends and colleagues, Todd Woodward, who's here at UBC, and Stefan Moritz, who's at Hamburg. So, again, just to take very much a sort of biosocial model of schizophrenia, and there are a number of psychological and social correlates, which I won't really go into, but just using very much a biological and cognitive model, the way that we tend to think about the illness itself is, that we have certain genetic predispositions towards it, which then translate into proteins and typically sort of aberrations or problems at the neurotransmitter levels, which in turn lead to dysfunctional neural networks, which can then lead to problems at the level of cognition, and then to different outcomes. So, the way that we think about it is we can think about it in terms of the illness as a whole, so sort of the diagnosis of schizophrenia, and there are those poorer functional outcomes there, and those seem to be tied into the sort of standard neuropsychological deficits that people talk about: attention, memory, executive functioning. And on the other hand, we can also look at specific symptoms that vary over the course of the illness itself. So these would be the state related issues. So the symptoms that people experience, like hallucinations and delusions, and we can think of them as there being certain biases in information processing, which are in turn related to dysfunctional neural networks and so on. So as we think about research on it, typically people have looked at schizophrenia as a whole and then tended to look at what are the factors which are associated with poor functional outcome. What my group has been particularly interested in has been on the symptom end of things. So looking at specific symptoms that people experience, hallucinations and delusions, and then looking to see, can we try to understand what are some of the biases that we see there, as well as what are some of the dysfunctional neural networks that are associated with those symptoms itself. So going from saying, rather than looking at it as schizophrenia as a whole, to look at the factors associated with specific symptomatology. And what I thought I would focus on today is just a subset of that, which is really kind of the cognitive functioning and the cognitive biases which are associated with delusions. So really, as we think about delusions or strong beliefs, what we want to try to understand are the processes which are associated with belief formation, and looking to see whether any of those show biases or abnormalities in individuals with delusions. And so the big questions that we were thinking about were, how do people arrive at decisions or develop those beliefs? How do people choose between different alternatives? And why don't we change our minds in the face of new evidence or disconfirmatory evidence itself? And what I thought I would do is just kind of talk you through some of our work that has looked at these specific questions. So how do people arrive at decisions? Like, how much information do people use to arrive at decisions was one of the issues that we were interested in. So we know that, if we looked within a sort of the context of how do people reason with the delusion? One can say, okay, look, these are beliefs that they already have. So what we've wanted to do with all of our studies is actually use a very neutral, non-delusion relevant context. And the first task that we've used, which Todd and I and a number of others, this was a lot of my PhD was spent kind of going to different places with these sort of jars of beads in my bag and kind of trying it out with different people. And the experiment is actually very, very simple. It's like you say, you've got these two jars with beads in them, and they're like in an opposite ratio. So let's say you've got black and white beads. One's got 80 black and 20 white. The other one's got 80 white and 20 black. And then what you say is, look, I'm going to just keep pulling them out from one of the jars. I'm going to hide them behind a screen, put a lid on one, and then just kind of take out the beads one at a time, show them, and put them back in. And all the person has to do is to decide which jar do they think I'm taking the beads out of. So what that actually allows us to do is that it allows us to quantify the amount of information that people are using in conditions of uncertainty to arrive at a decision. And then we can do kind of other things like, for example, look at the level of uncertainty, which would be the ratio of the beads itself. You know, like if it's 55-45, it's going to be a lot harder than if it's 95-5. And we can also look at how certain they are in their decision itself. And what we find is that people with delusions make that decision much faster than healthy controls, as well as people with a diagnosis of schizophrenia who don't have delusions. So that effect is somewhat biased, and there are certain variables like memory which seem to kind of cause that bias even more. But some studies find that about 40% of the folks who have strong delusions actually make a decision after one bead. Consistently, they say, you show them one, they say, it's from that jar. And they're very certain in it, whereas most other people actually take a little bit longer. And you can see how that would be helpful in real life. Now, Todd had developed a variation of this, which we call our fish task, which is you're told, well, you know, there's this fisherman and there's these two lakes that he's fishing from, and he's incredibly lazy, so he just leaves a stick in the two lakes and then he wanders off and he comes back and then he finds, oh, I've got a white fish. And the question is, which of these lakes are the fish coming from? So is it the one which is mostly white there or the one which is mostly black? And they're told what the ratios are. Now, one of the things that this paradigm allows us to do, which is a little bit different from the jars one that I showed you, is that it actually allows us to get separate ratings. So this is lake A, which is the mostly white one. We call this the matching lake. And this one would be, in this case, the non-matching lake. So where we can look at what's the likelihood that people think that it is from the matching lake, and what is the likelihood that it's from the non-matching lake. The importance of this is that we're looking at these two alternative possibilities, and we're not saying that they necessarily balance out. You know, I think it's from the white one. I have about a 70% certainty of that, but it's possible that it's from the other one. I mean, my certainty level is not going to be 100 minus 70, which is 30. It's actually going to vary more subjectively, and we can look at that subjective rating and the variation that happens there. And what we find actually is that when we kind of collapse across a number of trials that people have done, is that the rating that people give to the non-matching lake, that this is not congruent with my hypothesis, those ratings actually show no differences across our groups. But when we look at the rating, the likelihood rating, the certainty which is given to the matching lake itself, what we find is that there is a difference specifically with the folks with a diagnosis of schizophrenia with current delusions. Now, the interesting thing here is that the performance on this task actually differentiates from those people with schizophrenia without delusions, bipolar disorder, and healthy controls. So it's quite specific to the presence of delusions itself. And what we find is that just even in a neutral context, people are making a decision faster, using less information, and are more confident in the decision, which is congruent with their initial expectations. And we call this a hypersalience of evidence hypothesis matches, or EVH matches, which, because Todd and I like cheeseball old rock, we jokingly refer to as Eddie Van Halen matches a lot. So the idea here is, you can think that when I have an initial hypothesis, which is actually probably driven by my affect state, the things that are happening in my life, my past history, and so on, I have a hypothesis like, someone's watching me, and I match evidence preferentially to that hypothesis, and I have a higher certainty with it. So the second bit that we looked at is how do people choose between different alternatives, explanations, essentially. And we developed yet another variation of the fish task. We're not as obsessed with fish as these tasks might suggest. So what we do is we say, well, look, we've got this fish which is in this lake, and it comes from one of these different lakes. And which lake do you think it's actually coming from? This fish, is it coming from this lake in the middle, or is it one of these ones? And essentially, people give a rating of how likely they think it is. Now, one of the things that happens is we tell people, well, sometimes we're going to ask you to make a rating. At other times, we're going to say, we're just going to have the computer tell you which lake it thinks the fish is coming from. And we can look at the subjective differences between when I have developed the explanation myself versus when the computer has actually told me which one it's coming from. So what we're really looking at is the difference in subjective confidence between a self-generated hypothesis versus a hypothesis that was provided by someone else. Now, we know that one of the common biases that happen is we all tend to believe our own ideas with a greater level of certainty. But is that heightened in folks with delusions? And what we find is that, everyone is biased towards their own hypothesis versus one provided by someone else. But again, what we find is that specific increased confidence in self-generated hypotheses within the folks who have current delusions, even compared to a sample of people without delusions who have a diagnosis of schizophrenia, bipolar disorder, and healthy controls. So again, pulling those together, the fact that the explanations that I am generating are just going to feel more real, more plausible to me, that bias also seems like it's heightened in folks who have delusions and as they're developing those. And we can see how that, in turn, may contribute to those evidence hypotheses matches. Because I have a number of different possibilities, but there's one which feels more real to me, and I'm going to go with that, and then I'm going to start matching stuff to what is my initial hypothesis itself. So then we go to the next question of, well, I have an idea, I start matching things to it, but obviously in our day-to-day lives, we may have certain hypotheses, and we get a lot of disconfirmatory evidence. I may think something's going on, and it may be completely incorrect, and there's a lot of proof that that's not actually the case. But one of the things that we know about delusions is what people call the incorrigibility of it. They're unwilling to change their beliefs in the face of disconfirmatory evidence. So why does that happen? And again, towards that, we developed a task where we would present people with a piece of information, and then they're told, well, we'd like you to tell us how likely you think each of these explanations is given the information that you have at the moment. So you see that picture and you say, well, do you think it is that a man has just built a fence, or he's shopping for guard dogs, or he's just escaped from the barking dog, or he's playing with the dog? And some of these may seem more true at this point. So for example, at that point, it may be that, he looks like maybe he's building a fence or he's shopping for guard dogs. But then new information comes to light, which hopefully causes you to shift your initial beliefs and expectations. And then hopefully, by the time you see the whole series, it becomes clear that, it's not that he's built a fence or that he's shopping for guard dogs, but he just actually escaped from the barking dog. So what we have there are some explanations which, turn out to be true, and then other ones which we would call the lures, which may appear true at first, but then as new information comes in, your confidence in it should be decreasing. And what we find, again, when we've looked, we know that as with any belief, the stronger my initial expectation or the stronger my initial belief, the less willing I am to let go of it. Things I don't hold on to too strongly, I'm like, whatever. But if I hold on to it strongly, I'm less willing to give it up. But the extent of that So if we can think about the two kind of shifts that happen, there is as confirmatory evidence comes in, my bias increases towards certain explanations, and as disconfirmatory evidence comes in, my bias, I'm shifting away from certain explanations. And what we find is that, again, if we look here, so these were, what is the ratings on the initial ones as new information comes in and sort of by item number 3. And what we find, the group in pink there, the sample of people with schizophrenia and strong delusions, you see that they're actually less willing to change their ratings in the face of disconfirmatory evidence. And we call that the bias against disconfirmatory evidence, or BAID. And so we think that this also has a lot of face validity just in the phenomenology of how people maintain the delusions themselves. Whoops. So we think that they have a strong bias against disconfirmatory evidence, and as a result of this, the beliefs may not be properly disconfirmed because let's say I have a piece of evidence which doesn't fit with my initial expectations. I just sort of disregard that evidence and focus on the things which are congruent with my beliefs. So we have this hypersalience of evidence hypothesis matches. The things which don't fit with my picture don't get properly disconfirmed, and these get maintained and elaborated as those evidence hypothesis matches kind of broaden and intensify. And we, of course, recognize that there are a number of personalizing factors which interact. So, the expectations, my prior history, hypervigilance, or my affective state, memories, trauma, and so on. So those are all of a set of the biases, and there are others, but that we think at the level of cognitive functioning may be playing a role in the behavior that we observe, the delusions themselves. And then we've also done some studies, which I'm not going to get into for reasons of time, kind of looking at the neural systems which are associated with that. And most of my work has been on fMRI, and Todd's done some really interesting work integrating fMRI and MEG and EEG together as well, showing that within certain brain networks there may be kind of hyperactivity there, which kind of prevents or may be indicative of like the hypersalience of initial information and the inability to kind of update your expectations and change beliefs and so on. Now, of course, when we think about treatment and we're going from saying this is our research model or this is the illness model, the treatment for the most part is focused down there with the medications at the level of the neurotransmitters or the receptors and so on. But is it possible to use the research to help our clients better understand their cognitive biases itself? Will this knowledge in turn help with symptom improvement? And Stefan Moritz, about 10 years ago, had developed a series of talks to clients to say, here's what the research is saying and so on, talking about those cognitive biases. And a number of clients started to say, hey, you know what, I can see how that might play a role in my day-to-day life, or, I can see how that, like family members would say, I can see how that is happening with our clients itself. And so Todd and Stefan went back from there and said, well, can we kind of, use this and develop this into a clinical framework of sorts? And the outcome of that was what we would call the metacognitive training, which is the group intervention, or there is also, like we just kind of call it MCT+, which is the individualized treatment there. And we called it metacognitive training because really we're saying, these are some of the biases in thinking that happen to all of us and may be exacerbated under certain conditions. I want you to reflect upon your own thinking. So thinking about your thinking. And so the MCT, we hope, actually targets it at the level of the cognitive biases, and we do know that other interventions like CBT also work at that level, at the level of cognitions. So both components have a number of common, or both treatments have a number of common components. Both methods help to help individuals to understand those cognitive biases and find ways to think about their beliefs and their symptoms. the way that CBT works, of course, is we get people to say, well, what's going on for you? What are you thinking in that circumstance? Is that necessarily accurate? How do we evaluate evidence and so on, right? So we're beginning by helping to understand their own individual experience and then go from there to saying, could there be any biases in your thinking? And MCT is sort of going the other way around. We're saying, I'm going to not look at it because that might make people defensive. They may be unwilling to consider it, but we're just going to actually say, here's some cognitive biases, and then kind of just show how those may play out, again, in a completely neutral, non-delusion relevant context, and then expand it out from there to see, could that then have some effect in your day-to-day life? Oops, this went a bit. So the MCT package itself is available. It's hosted in Germany, where Stefan works at the University of Hamburg site, and it's essentially just a series of PowerPoint presentations going through the different modules itself. And each of the modules focuses on one of the things. So, for example, it may be on jumping to conclusions, so the evidence gathering process, or the bias against disconfirmatory evidence. And there are, of course, a number of overlaps in how those play out, but it's just a way to try to get people to think about and reflect on whether this may be happening in their daily lives itself. So a lot of it just involves kind of little games like that. So, for instance, this is an example from the second module, and where they're told, look, you're going to see a picture. There are several possible interpretations. We want you to tell me how likely each possibility is. And then, people kind of discuss it, raise hands, debate, and so on. So you're looking at a picture and you say, which of those choices is it? Is it a smiling face? Is it a bowl, a boat? And so on. And then with each new piece of information, our expectations may shift. Okay, was it a boat? Is it a sled? And then as new evidence comes in, you may realize that it is one particular one. So in this case, it's a rocking chair. And so you go from there to saying, well, could you see how if you came up with an idea initially and you didn't change it in the light of new things, the outcome may not be the same one. Like what it looked like at the end is not how it started off. And then as the hour progresses, to think, do you think that can play a role in your life in any way, shape, or form? And then as a homework exercise, people say, well, I want you to go away this week and then think about one time when you've made a decision really quickly and then afterwards you found out that what you thought was going on is not actually what you thought was going on. And so similarly, there are sort of particular exercises that people do and have little homework things in between. And they go through a number of training modules. So we do it as an 8-week program with 16 modules, which work through those twice with slightly different stimuli. So we look at how people attribute causes to events, how much information they're using to make a decision, how willing we would be to change beliefs, emotion recognition and memory, and so on. And the idea, of course, is that eventually we would be able to go from there to slightly more affectively laden instances. For example, my boss doesn't say hello to me. In the CBT world, we would think of that as, is there some catastrophizing where you thought I will be fired? But we're trying to get people, again, to do the same thing. So, did she see me at all? Are there other explanations? Are there other possibilities which I haven't considered because I'm zoning into one? So the end product, in some ways, is quite similar to where we would go with a CBT framework itself, but kind of coming at it from the back door. So again, we're recognizing that we're getting people to consider multiple explanations, look for evidence that might help to disprove the belief, and really take your time in making a judgment when you're uncertain. And the MCT also looks at certain memory things and kind of talks through findings like the Donja-Rees-McDermott paradigm to recognize that, our memories aren't perfect, they're reconstructive processes, and they're biased by our affective state, much the same as our reasoning might be as well. And ultimately, we also want to get people to, so there is a module kind of talking about self-esteem. What I like about this is we've done a bunch of small RCTs, mostly done by Stefan's group in Europe. But when we look at kind of the subjective responses, people would say things like, I'm walking down the street and I hear a stranger swear. my initial kind of reaction is that the person's angry at me, but I think maybe he's just having a bad day, or maybe he's talking to himself, or just because he said something doesn't mean it has anything to do with me, and it may have to do with the chance or circumstance. So that's really like from how we attribute causes and so on. And similarly, this idea of getting people to evaluate evidence and maybe change their own responses in the face of things that shift away from those initial beliefs and expectations. MCT has been shown to improve positive symptoms, particularly the delusions, prevent relapse, and improve those cognitive biases itself. And we've just begun recruiting patients for a 5-year CHR-funded study to look at the efficacy of MCT and compare that to cognitive remediation, and to understand the brain mechanisms associated with change. So this whole thing was a plug to send people to our study. So if you have patients who might be interested in taking part in the groups, you can send them our way. Thank you for your attention. And there's a number of people to thank, including Todd and Stefan and Devin, who's back then helps a lot study. Thank you.
I know we're running just a titch late, but we'll just have an opportunity to ask our panel. If you'd like to come up, if you have any questions, I'll just ask the panel to hover around here so that you can be by a microphone. Does anybody have any comments or questions about some of the topics that were discussed? Are you going to make me run up there, Suja? Okay.
You mean if I'm using a psychological test? Yeah, there's been some interesting talk about that. I prefer to use the norm of that the person identifies with, or else some tests actually have a neither, like the personality assessment inventory, which has a neither option.
Yeah, so the MCT program itself, the manuals, and actually all of the PowerPoints that we use for the training are on the website. It's uke.de/MCT, I think it is.
Okay, well, thank you very much. We'll just take a break. See you back at 1 o'clock. And thank you very much for our presenters. If I could ask all the speakers to meet with me and the conference committee in the meeting room that's just in the foyer here, I'd appreciate it. Thanks. See you all at 1.
Yeah, that was like Lorraine's
Hey, Mahesh, do you know where lunch is? If you're joining us? Yes. Okay. That room on the left. Leave what? We can leave all kinds of things in here, but I'm taking the laptop with me. Okay. Yeah. Would be what he's doing.